Pro 8. And then we would seek assurance that the GP practice had acted upon that bulletin as requested in the bulletin. So the conversation at Primary Care Commissioning Committee at last time was conversation about a light touch approach, and I had further conversations with the local medical committee about this. And the paper that I've presented to you is draft, and in hindsight I think warrants a bit further discussion since I've submitted that paper, and I'd welcome that further discussion with Primary Care Commissioning Committee. So first of all, and I apologise, you know, in hindsight I should have had discussions with our governance team, and the reason I haven't done that is they are very busy responding to COVID at the moment, so a lot of pressure on that team. So I think this warrants going through the governance team though properly. And then the other consideration that I think we should discuss is that this should go to the Quality Committee, which Julie also chairs, because of the quality element. So it doesn't say draft on it. It should say draft on it. It's more for discussion at this committee. You know, I'm happy to take it forward to the next stages after that.
Okay, have we any questions for Laura, please?
Yeah, sorry, Julie, I was trying to turn my microphone on.
Fine.
Laura, a really simple one for me. As a lawyer, which for the CCG will be Abby Coombs, had any sight of this?
No, so that's what I'm referring to in terms of the governance side of it, Phil. Okay. And that I think Abby has seen it since it was submitted. That is an oversight on my part. I'm happy to, you know, have those discussions with Abby outside of this.
Okay, well, I'm no lawyer, but I would expect that the process that's outlined in your flowchart, particularly that at stage 5, will change. As an assurance process, it's just not adequate in my view, and I say that with my Chair of Audit Committee hat on. Let me preface what I'm going to say by making very clear that my mindset is not that everyone is guilty until proven innocent, is a devil until they sprout wings and fly off and we say, well, look at the halo. But we can't have a process where, in effect, the medicines management team on behalf of the CCG is almost apologising for being there. If a GP practice does not respond to a reasonable request to provide assurance to the medicines management team, then we can't have a situation where we go back to them with wording that says, hi, we're just following up on this. We've not received a response, but we consider that the GP practice has taken the required actions. That is not a due diligence process, and I think it unwittingly exposes the CCG to considerable risk if there is a situation that arises with that GP practice that hasn't responded, where there's a problem in terms of medicines management. The other thing for me is that in terms of governance is there's no escalation within the CCG. So, you know, who more senior gets to know that we've got a GP practice, which by exception is not responding to reasonable requests from the medicines management team about information on the use of a particular drug to the patient population. If the intention in the wording is to effectively indemnify the CCG, in other words, the onus is on the GP practice to respond. The fact that they haven't, we are telling them that we consider as the governance organisation that there's nothing wrong, and if that's not the case, then they need to respond. In other words, that acts as an indemnity for the CCG. Then it needs to be plain that that's what it is, both by the sender and the recipient. But that's not the case at the moment. It just reads to me like we think a nil response is everything's rosy in the garden. If we get a situation which does go pear-shaped with the use of medicines in a GP practice that hasn't responded, then I do not think that any reviewer would say that the CCG has operated with due diligence, and I think it exposes the CCG to risk. I suspect that's what a lawyer will say, so I think the process will change.
Laura, would you like to respond there?
No, I think it's what Phil has said. I think as it has raised some queries with other people that it's been presented to. So the light touch approach was the LMC view. As a collective, there was quite a few people involved in that LMC. So I have, taken that model on board, and that's what I've presented to the committee. But as I said at the beginning, I think this warrants further discussion and consideration, as Phil has alluded to.
Yeah, thank you. Oh, sorry, Andrew. Yes.
Yeah, I think Phil's points bang on. Really, it's great that it is light touch in the sense that it's not asking too much from practices, but I think it's completely within the CCG's right to be very clear about where its responsibility ends and what it's expecting. And I don't think that the LMC would have any issue with that at all.
That's really good to hear, Andrew. Thank you for that. And I share Phil's thoughts on that, actually, and the fact that it is a quality issue. So I'm happy for it to come to the quality committee if you can do that. So I guess, Laura, you've got work to go away and do now. So pull on the skills of our team there. So if you can speak to Abby about the legalities of this, and then. But sorry, Tim.
Yeah, these come up all the time, but in different contexts. I'm a big believer in actually making sure that things happen, not just being told things are happening. I'm just a bit concerned we turn it into another tick box. So the action that society needs is for the alert to be noted and the practice to take action.
Yeah.
I think that's a contractual obligation. We've got an awkward thing there where, as a practice, I just go on and do that. I get a national link. That's what I do. It's my job. But then we've got this awkward thing if someone has to check that I'm doing my job. Now, there are ways of checking to do my job. You can either ask me, am I doing my job? To which I'll say, yes, I'm doing my job. You can check and come and look at my practice and see if I'm actually doing my job. Or you can look at my data and see if what I've said matches with what I'm doing. Then, once you've decided whether I'm doing my job or not on one of those three levels, you've then got to decide what you're going to do if I'm not doing my job. And that's where the GMS contract gets a bit, well, I've always found it a little bit woolly, and there's no clear sanctions. There's either, I don't know, what are the sanctions? You lose your contract. There doesn't seem to be a fine. There doesn't seem to be I have to go to prison or anything. So absolutely understand why we've got to do this. I just think you've got to be clear what you're trying to achieve. If you're trying to achieve indemnifying the CCG from comeback, that's one approach. If you want to make sure this happens, that's a different approach. And I just wonder whether a medicines management team has the capacity to enforce this and do all the detailed searches you'd have to. Because there are loads of these, most of which are things we never use in general practice. And they come through into the sort of email trough of doom. So it's really helpful that the CCG pick out the ones they think are likely. So a clear process, but also be clear what you're going to do about it, and what you're trying to achieve by doing it, I think, for me.
And I believe that's what we're looking for as well. Laura, you popped your hands up. Nice to see you, Abby. We'll be calling on you in a second, I think.
I feel I welcome this conversation because I feel like we've gone maybe full circle from what I presented without a paper at the last Primary Care Commissioning Committee, in that the request was we only raise with the practices the things that are pertinent, because we know there are many, many, many safety alerts, and as Tim has said, that you know, some practices don't even prescribe those things, so they're irrelevant and they just need to be discarded. But there's some that are really pertinent and national attention, and for very good reason. So I give the example of sodium valproate. So we pull out those pertinent ones, and we follow them up just to make sure. And what we ask is quite clear, and it's normally, you know, have you done an audit, and, you know, have you reviewed all your patients, and have you done this, and have you done that? And the ask is normally quite clear. So we are seeking assurance that that has been done. And the next part of that is then, you know, what do we do when we don't get responses? So the sodium valproate, for example, you know, we can chase a practice 3-4 times and not receive a response. So my, you know, question is, where do we take that as a CCG, and what do we do with that? And I'm not sure we're quite clear on that. And that was why I suggested that it come to Primary Care Commissioning Committee or potentially QPEC for raising that. As to me, it's a risk if we don't get that assurance from our practices, because I think if you've done it, then why wouldn't you just say you've done it? And I think if you haven't done it, it raises concerns. If you don't say that you've done it, it raises concerns. And I just, you know, as a GP, yes, it's your job. The General Medical Council has good practice guidelines, and domain 2 is responding to safety alerts by other organisations, and we would be classed as another organisation in this instance. So I'm a process-driven person, so I really desire a process, but I want a process that we can all agree on, and that everybody knows what the process is and understands and responds accordingly.
Thank you, Laura, and thank you, Tim, for your comments too. I think they're very helpful. We, you know, it's really good to know that some GPs don't see it as a problem, process as a problem, but then we do, rightly so, we do need to find the legal aspect from a point of view of us as a CCG. Abby, have you anything for us here to this point?
I don't think so. I think it's, I'll link in with Laura afterwards. I think it's Tim's input's helpful. If for no other reason than he's cheered me up with a Christmas tree behind him. But Christmas tree aside, I think there's something about, even if contractually we can't do anything particularly specific, there is something about hearts and minds whilst trying to support primary care at a time when they're really pushed anyway. So I think me and Laura probably need to try and navigate our way through that as best we can, and try and make it as useful as we possibly can, acknowledging that actually what we're trying to do is ensure quality and safety is at the foremost for everybody.
And I'm seeing lots of nodding heads here, so I'm hoping that that we're all in agreement. So if I say for this piece paper that we've had presented to us today, if we hand it back over to you, Laura, and Abby to work on, I'm happy for it to come back to me for the quality part. You know, and if anybody comes up with anything else that they'd like to add, you know, if they'd like to get in touch with Laura about the process, and I'm keen to move this forward. To me, it's really important. Simon.
Thanks. Are we clear on what other CCGs do? Because I am conscious, like Laura, that we've revolved full circle around this. So I'm just a bit concerned that simply revolving around the circle again will lead us back to the same place. So have other people solved this problem, and how do they sanction practices who don't comply with the process?
I can explore that further, Simon, in terms of what happens if practice don't respond. I know all medicines management teams will send out similar kind of requests, and we are moving to one of our technicians is becoming a medicine safety officer, so we'll form part of a network with all of the CCGs and acute trusts to focus purely on medicine safety. So we can link in with that network to find out that question, because I don't think we know the answer to that about what happens if general practice don't respond and provide that assurance. So I can take that away.
Okay, is that okay, Simon? Yeah. Lovely, smashing, thank you. So we were asked to approve this paper. It's clear that we can't at this moment in time. So if we, you know, if we move it on as quickly as we can and get it back as quickly as we can, please. Okay, we're all in agreement there. That's lovely. And now it's over to you, Abby. Thank you for coming. And Abby might be another one of our delegates that has to bob back out again because there's so much going on. So thank you for joining us. We do appreciate it. So it's over to you, Abby, please.
Thanks. I'll be pretty quick with this, Julie. It's just the terms of reference to approve. The only change that we've got, obviously, is since Andrew has left the organisation and Steph is acting in the interim post, we've just changed her job title within the terms of reference. Otherwise, they are statutory terms of reference set out by Nhs England. We've got very little flexibility in them. It's one of the few committees where we can actually say, finally, to our audit chair, you can have an opinion, but you're not a member of the committee. And you can't be the chair of the committee. That's the main thing. So unusually for Phil, he has to take a back seat. However, the terms of reference are exactly the same with that one exception. So it's just for you to approve, and then obviously they'll go up to governing body in the usual process. What's
not to like then, Chair?
Andy got told off as well for misbehaviour. And with such a minor change, I'm sure that it's okay. And thank you, Steph, again for stepping up and stepping in. And it is good to see you at today's first one of these meetings, not the first one of introduction meetings today, although you're a well-loved and long-standing member of staff. So, but nice to see you in a different role. It's good to grow your own, isn't it, as we all say. So thank you, Abby. I really appreciate
Julie.
that.
I'll dip out and come back on again later on for the other items.
Okay, really appreciate that.
Thank you.
Simon, you're next up, please. If Simon's our Chief Finance Officer.
Thanks, Julie. So I'll take the paper as read. Essentially, as reported in previous months and in keeping with the rest of the CCG's finance, any variances from budget or additional expenditure for COVID is subject to a national, what's called a national true-up approach, whereby any variances are either withdrawn if it's an underspend or subject to additional monies if it's an overspend. The idea being that all CCGs will get back to a break-even position for expenditure which is reasonable and genuine. And the paper that's presented here today, which is up to month 7, confirms that that same process happens for the primary care budgets. In other words, we expect them to be, broadly speaking, into a break-even position. As I did with the Finance Committee this morning, it is worth mentioning that some of those allocations that we are anticipating to spend against, or indeed have already spent, we've yet to receive the funding for. We've not heard we're not going to receive it, but equally we haven't yet had it. And certainly that number, that amount of money we're waiting is getting bigger by the month. Of key interest for this committee on page 29 of your pack is 1.1 million, which relates to an allocation adjustment for primary care, but also the PCN additional roles funding of £1 million. We were advised to include those expenditure plans within our planning submission at month 6. So that covers the month 7 to 12 part of this financial year. We were told to include the expenditure, but we're advised that the funding had yet to be confirmed. So that appears as a risk in our plan. We haven't been told that it won't arrive, but like the other funding I mentioned in terms of truing up back to break even, this is for primary care a significant element of money that we've yet to have. Clearly, PCNs will be going ahead with additional role recruitment. They would be rightly looking for the CCG to reimburse that funding. However, if it happened that nationally it was decided that that funding wasn't going to come, that would give us, to the maximum extent, £1.33 million worth of problem, which we need to be mindful about. So again, I mention it just as an important consideration for the committee. I'll probably pause there, Julie, and let people ask any questions. But that was the point I wanted to emphasise this month.
Yeah, thank you, Simon. I appreciate that. Tim?
Just to confirm, Simon, is that based on our projections of what we'll recruit? Or is that based on already committed expenses?
No, that's based on the national allocation. So it's not necessarily dependent on what you have recruited or what you intend to recruit or what you might actually recruit.
Because we've all been very aspirational in our recruitment plans for by April. Some of us will achieve that because we're very aspirational, but some of us might not, because the recruitment market out there is quite challenging. Okay, so it's not just because everybody's aspired to meet the top allocation that you've got this higher bit. It's just because the government haven't covered off that money
yet. Yeah.
Right, so it could come back a little bit, but it's right. I see. I understand now. Thank you.
Thank you, Tim. Thank you, Simon. Any more questions for Simon? Okay, thank you, Simon. But is Phil has, we've disappeared. No, it's okay. So moving on, and Tim, you've expressed a conflict of interest here. We're handing over to Fiona, and it is Fiona. Oh, and Gary. So I'm not sure who's doing the presentation.
I was going to kick it off, but I'm really sorry. I need to dip out for a COVID meeting, so I will leave it in Gary's capable hands, and I will be back in a few minutes. So hopefully, won't miss too much. Sorry about that.
Okay, that's okay, Fiona. Shall I hand it over to you? Do you want to introduce yourself and explain what you're going to chat about?
Hi, I'm Gary Young, lead officer for primary care in Central York. The paper that has been submitted is a requirement of the GP Forward View monies that have been allocated to primary care for two pots really. One is organisational development of the PCNs, and the other is winter resilience and extra capacity. Fiona's presented a paper which I think is fairly straightforward. The purpose of the paper is to gain approval so that these funds can be released regionally to the PCNs to get ready for winter. The only point of note I would pick up is that in point 3 of the paper, which is on page 3, the chart outlining the monies is in error. It's picked up the national funding rather than the local PCN funding, and I can run down the total sum, I think shown in the paper, sorry, I'm flipping between screens here, is just over £2 million, which is for the whole of Humber Coast and Vale. The total for Vale of York PCNs is £398,841, and I will share that revised table. So it varies between about £33,000 and £60,000 per PCN in total, depending on the size of the PCN by patient list size. It doesn't vary between 230 and 300,000. So that's just to note. But I will send in a revised table for that.
Gary, sorry to interrupt at that point. Could you just shout out the local numbers again?
Yeah, certainly. So for Tadcaster and Selby Rural.
Oh, just the total will be fine. Sorry.
Sorry, 398,841.
841. Thank you. So yeah, so the plans that
PCNs have been asked to submit cover 5 areas, which is leadership, planning and partnerships, use of data and population health management, integrating care, managing resources and working with people and communities. And then the winter money is really about putting that extra capacity and additional resource in to manage over winter. I think of those 2 aims, looking at the first aim, the organisational development, I'd say PCNs across the whole of the Vale of York are really well established now. They're all working well. And I think all PCNs see this funding as timely and welcome. Because actually, in terms of improving the governance, involving the practice teams and that system working, they fit into those 5 headings very neatly. And I think all the PCNs have put similar but locally appropriate plans in. And there's nothing that when we've reviewed them stands out as causing any concern at all. In actual fact, it's a positive development for PCNs. And I think in terms of the winter resilience and additional capacity, I think that's really welcome, because I think with practices responding to COVID, with all the pressures that they're under at the moment, including increased demand, flu vaccinations, COVID vaccinations, staff absent through self-isolating and having COVID themselves, and also the pressures across the wider health and care system this winter. Like I said, I think it's welcome support, both for the practices to improve their own resilience and also for PCNs to work together to support each other if a particular practice within a PCN is struggling. So on that, I think it's an unqualified recommendation from Fiona and I as being the leads working directly with the PCNs, and welcome to take any questions, but we would warmly welcome approval at this meeting today so we can get the funds released and working for the PCNs.
Any questions for Gary, please? No. It was a really good piece of work. Thank you both. Very informative, and obviously it shows you each place is different. So yes, thank you. I think I've got one question, and it's we were really keen to roll out the flu vaccination, and are we reaping the rewards of our timely intervention there?
Yeah, I think so. I'll maybe defer to some of the GPs who are attending today, or maybe Paula if she's here. But the last time I looked, I think the overall uptake across the Vale of York was above 75%, which is probably the highest flu uptake that the area's seen in a long time, at the very least, certainly in the time I've been here. So stunning, really. And I think the preparations across the whole of the Vale by PCN and by locality for picking up that 50+ age group, which are now eligible for flu vaccine, and making preparation for the COVID vaccines. I think York, the whole of the Vale of York, is outstanding in what it's achieved and what it can continue to achieve. But what are actually really very demanding asks, and haven't always landed as positively in other parts of the country as they've been managed in York by the GPs.
Yeah, I think we talked this morning a lot about how difficult it has been to spin all of those plates, and we don't actually know what we don't know at this moment in time. So we don't know when the vaccine's coming. We don't know which one we're going to get. So all of those have got logistical implications. You know, but for me, there's still that really positive can-do attitude. It's about people. It's about patients. It's about it's caring. Welcome, Sharon. Nice to see you.
Can I make a comment, please?
Yes,
Julie?
please.
I mean, I would certainly echo what Gary has said in terms of the uptake of the vaccine, which has been very positive. But we're also seeing lower flu prevalence of seasonal flu this year. So the rate of illness is much lower than in comparable years, which I think also bears out the success of the programme. So as well as the uptake of the vaccine, we're seeing improved population outcomes as well, which I think is very positive.
That's really good to hear. Thank you, Sharon. Right, Gary, is there any more from you that we need to be discussing at this moment in time?
No, we just need the approval from this committee for the plans. And if there's no further questions, I'd just say thank you very much, everybody.
Thank you. Approval for the plans? Yes. Yeah, an absolute thumbs up. Thank you very much. And again, thank you very much for your hard work, and very much appreciated. Okay, so moving on, Stephanie, it's over to you. If you want to introduce yourself, Stephanie's going to do a COVID update for us.
I'm Stephanie Porter. I'm the Interim Director of Primary Care at the CCG. So I'll kick off. Obviously, others on the meeting might have other pertinent updates, particularly Sharon about the testing. In general practice, incident rates, COVID cases are manageable, and I say that with a qualified point. Incident levels per 100,000 in York are stable at around 170 per 100,000, where other areas in the Humber Coast and Vale are much higher. Practices are still being affected by periodic staff absence, and depending on the size of your practice, in some respects, depends on the impact of that. But practices, the support from Peter Roderick, Abbey, to practices on outbreak control, I think is appreciated, and on the whole, practices have worked really well to manage practical issues and continue to deliver services. Underpinning that, we have a self-reporting system. So practices by 10 a.m. every morning actually report where they are in terms of their ability to cope. And we go from a scale of 1 to 4, and on the whole, our practices are in the 2 to 3 level, which I think indicates that there is stress in the system, but our practices are managing. Where we are seeing the impact is that people will perhaps know on the news, the East Coast in the Humber are affected to a much greater extent, and a couple of weeks ago they were the highest rates in the country, and we've seen the impact of that across the patch in our acute services as they offer mutual aid. And what that means is that our main hospital site, York Hospital, are enacting and increasing their surge planning. So they are converting more of their beds to COVID positive beds and wards. That has twofold impact. One is that as you move to a COVID positive ward, you increase the social distancing, so there are less beds available. But actually what that means is that more of the site is used for positive patients, and therefore the staff have more exposure to positive patients. So what then results is that there's less beds available to do activity, elective activity that needs an inpatient stay. You can see this ripple effect through the system that then has the potential to impact on patients who then need to be contacted for a delay in that elective care that then could mean those patients contacting GPs for support when elective care isn't on hand as they anticipated. But partners across the system are really working well to manage that and make sure that the risks of that are mitigated. I'll pause there and just see if Sharon wants to come in on the testing, and then I'll come back on, or maybe we'll jointly talk about the COVID vaccine, which is probably the light at the end of the tunnel for all of us, although I won't use a football analogy about penalty shootouts.
Yeah, so I've got the more up-to-date figures on rates than Steph just shared. So for North Yorkshire, the most up-to-date rate is 207 per 100,000. That's the 7-day rate. That is up until the 20th of November. And York's rate is now down to 132 per 100,000. So both rates for North Yorkshire and York are falling. York falling faster than North Yorkshire, but nevertheless, North Yorkshire is heading in the right direction. The areas of North Yorkshire that have the highest case numbers at the moment are Selby and Scarborough. But as I've said, falling even in those areas. Hull still is the area of the Yorkshire and Humber region that has the highest rate. Their rate is 530, so you can see there's quite a considerable difference there. York's positivity rate is also falling, so we want the positivity rate to get to below 5%. That's the World Health Organization recommendation, that if you get the 7-day positivity rate below 5%, then that indicates that you're having low community transmission of the virus. Heading in the right direction in York, where we're just over 8%, we're now below 8%, so heading in the right direction again, and fingers crossed that will continue. Seeing some outbreaks, particularly in care homes and schools, couple in businesses, but all very well controlled. And I haven't got any particular worries on any of that at the moment. And then hot off the press, we've had confirmed that both North Yorkshire and York is going into Tier 2, where national restrictions are lifted on the 2nd of December. So for York, that means we're returning to Tier 2. We're in Tier 2 before the national restrictions were introduced in November. York, North Yorkshire at that time was in Tier 1, so they will be joining York in Tier 2. The rest of the Yorkshire and Humber region is in Tier 3. So that's kind of news that's just been published today. In terms of testing, in York, we're preparing at the moment to submit a bid to do enhanced testing. We're not intending to go down the Liverpool route of testing absolutely everybody in the population, because our prevalence rate is considerably lower than Liverpool when that was introduced. But we will be expanding asymptomatic testing as part of our plan to control the virus and get our numbers down. And we're looking at that being a combination of a large testing site that people will be able to book and access a test there. This won't be for people with symptoms of COVID. They will continue to book a test at the existing testing centres. These will be asymptomatic testing centres. And then we're also looking at options to have mobile testing abilities. So if we have we can see that there's been an increase of cases in a particular school or a workplace or in a particular part of the city, we'll be able to deploy a mobile testing kit, testing site in those areas. And then we're also looking at the ability to post tests out as well. I understand that North Yorkshire are looking at something a bit similar. We're a little bit ahead of North Yorkshire in our planning in York, but they're looking at doing something very similar. And both North Yorkshire and York have our local contact tracing services now up and running. North Yorkshire's, I think, has been up and running since last week, and they're going very well. And we know that local contact tracing is much more effective than the national contact tracing. We can provide more targeted support. Yeah, we're supporting GP practices with vaccination. I've already had a couple of meetings with Nimbus and conversations with Michelle Carrington as well about how not just public health but the council can support COVID vaccination programme. And I know that exactly the same discussions are going on in North Yorkshire. So the CCG can be assured that both local authorities have come out publicly and said that we will provide whatever support practices need in order to be able to deliver an effective vaccination programme. So I'll stop there.
Thank you, Sharon. Thank you, Steph. And any questions for either Steph or Sharon? No. No. Thank you both. That was a really informative report, and it looks like we're moving in the right direction locally, doesn't it? So thanks again for all of the hard work that's going on there. I know it's not easy. Right, I can't see Abby. I actually need Abby for the next item. Is Abby available, Michelle? Can you say, or is she tied up?
I'm just going to message her and say we're a bit ahead.
Okay. You just bear with us for a few minutes. I'm sure that we can either get Abby or we can move on to David.
Julie, my two papers will be pretty quick, so I'm happy to get going.
Yeah, that's great. If I introduce, well, you can introduce yourself.
Yeah. I think my camera might have stalled at an inopportune moment there. So, right. So, yeah, my name's David Eiley and I work for Nhs England in primary care. I think the first agenda item is the annual report, the annual chairs report that needs to come through. So, as part of the requirements of being a fully delegated CCG, the committee needs to receive and approve an annual chairs report, identifying, amongst other things, committee membership, quorum and attendance. As well as some of the key programmes of work that were undertaken in 2019-20. Some of the key achievements included in the report are the formal approval of the registration of the primary care networks and the development and oversight of workforce plans and investment into the primary care estate and development of the CQC Ready programme, as well as supporting practice mergers. So as I say, it's just part of the requirement of full delegation. So the committee is just asked to receive and approve the annual report.
Right, at this point, I'm expecting you've all read the report and understood the report. Are there any questions here for David? That's good. Well done, David. So at this moment in time, I'm asking you to accept and approve the report. Yeah. Yeah, going by the nods and thumbs up, that's fine. And David, if your next item's quick.
Yeah, absolutely. It's just the Nhs England update. So I won't spend too long on it, as much of the items have already been covered off. So I'll just mention the one bit I will mention is that PCNs were asked to submit their recruitment plans to the CCG for the additional roles reimbursement scheme. Collectively, the plans suggested that across Vale of York, PCNs, there are forecasted to have recruited an additional 88 whole-time equivalent members of staff by the 31st of March 2021. Clinical pharmacists, social prescribing link workers, first contact physios and care coordinators are the most popular roles that are being recruited to. I think the other information is some of it's been covered off and can just be noted.
Yes, thank you. I'd agree. We have chatted about a lot of those. It was either this morning or this afternoon. Brains going. Any questions, please, for David? No. Thank you, David. We're just asked to receive those papers. Thank you for all of the work that's gone in behind both of those papers. Much appreciated. So we're just waiting on Abby around risk. I'm not quite sure how we're doing there, Michelle. And I think for everybody to bear with us, it's really difficult times. I think
I'm just going to have another go at catching her. Lovely,
thank you, Michelle. As I said, at the beginning in the introduction, many of our colleagues are pulled away working tirelessly for us around the COVID risk. Yeah, we've Sharon's having to leave us as well soon. So yeah, we're going to be dropping like flies, unfortunately.
We give it a minute and Nabby's still not free because she's probably scheduled for 10. I can take this item.
That's brilliant. I was actually just looking for you as well, Steph.
Yeah.
Shall we go ahead then?
Yeah.
Michelle, anything back from Abby? If you just tell her that we've asked Steph to do it on her behalf. I do appreciate that she's just she's juggling here.
Yeah, that so colleagues who sit on our various committees in the CCG will be aware that the way in which we report our risks go to QPEC, Finance and Performance Committee. We've been discussing and reviewing, given the position that we find ourselves in with a pandemic and approaching a EU exit, whether there should be now a consideration, whether there should be a separate risk report that also comes into PCCC so that this committee is cited. Previously, I think the view was always that if a risk was identified that was for primary care or pharmacy, the risk would either be financial or patient safety, and therefore that's why it was routed. So I think there's just a consideration to this committee about whether they would welcome a separate risk report that comes into this committee.
Right, can I throw that open to everyone and see if we've got any yeah or nay views on that? I think I've just heard a pin drop. I've lost my wingman. I've lost Phil Goatley there. I'm quite surprised he's not speaking to me there. Oh, there he is.
I won't surprise you, Chair, that my view is that it should.
Yes.
Risk is ever present, and the CCG needs to demonstrate due diligence in considering this. This is a very important committee. in terms of on the ground delivery of service to the populations of Vale of York. Yeah, I do think it ought to be. I mean, it ought to be by exception. So we don't want to inundate the committee with paper, but certainly there are germane risks, and Steph's just mentioned two of them that that this committee ought to be considering and taking a professional collective view on.
Sorry, Phil. Tim, please, can we go over to you?
Yeah, I don't like a void. If you're struggling for punters to say something, I'll always have an opinion.
Don't let me down, do you?
It's interesting because obviously I'd not really heard of these until 10 years ago when I first got involved with the CCG. And they come up a lot in these kind of things, and they do occasionally come up in practice, but they're a bit more fluid. And I suppose it's just being really aware of what you're using them for. And I appreciate as a CCG organisation you have to do them, but you have to be careful they're not just weather forecasts, and that you can actually take some appropriate actions. Otherwise people get red blind, whatever you want to cause it. I spent many governing bodies looking at the risk and seeing all the reds and going, yeah, they're still red, and there wasn't any action we could take. So, you know, you could say, yeah, we're in a pandemic and we've got Brexit coming. I would like to think I could do something about those, but we're very limited as to what actions we can take. So I think they absolutely need to be there and be considered, but we also need to be quite specific so we don't get sort of overwhelmed with hopelessness, if that makes sense. Just, you know, if there's one of these, it's no good just saying, oh yeah, isn't that bad? We've got to have some mitigating sort of approach to it. Otherwise, we're just another committee looking at a load of red risks. So you know, they should be more useful than they are. So my question is, why aren't they more useful? Do they just tell you you're heading for the iceberg, but you're not able to steer the ship around it, and you just get closer and closer until, you know, that's a bit depressing maybe, but you know what I mean? It's like Brexit's been coming for years. It's a red risk. You put it on the risk register. Are we any more prepared now than we were a year ago? Because we don't know what to prepare for.
Yeah.
Got
Thanks,
no
Tim.
deal yet. So anyway, yeah.
Yeah, thank you, Tim. Yeah.
I think if Abby was here, she'd probably have prefaced what I had said by describing the fact that we've split our risks into a board assurance framework which identifies risks that, as Tim responded to, they are in the system but we can't influence. And actually, what I think you hear at PCCC is our practical mitigation to those risks that we can have something about. So you hear our mitigations, and we talk and we preface what we think that risk is. So today we've heard about the fact that we can formally release money into the primary care system that was badged for something else under that organisational development and GP forward view monies, and other such things. So you're right, Tim, there's something about how we make sure that we're prioritising the work and the work that's actually going to mitigate the risk, so the risk doesn't become a reality. Or indeed, for this committee, if there is a risk that is going to land and materialise, that we understand that we've done everything to mitigate its impact. And I do think that those conversations and formal reporting do go through QPEC and F&P. It just seems somewhat unusual that PCCC doesn't have a top slice of those very specific primary care risks.
Laura, I saw you click on when we started chatting about this. I'm assuming you wanted to have... No, that was wishful thinking. Tim's just laughing hilariously at me now, and I'd agree actually, because if it's appropriate to bring it to this committee, in a format that we can easily understand, it flags up straight away to me that this is something that we need, you know, to get onto as soon as possible and to get sorted. Not just to look at it and think that's a nice shade of red. It's about how do we change that red into a green. You know, this is because that red's people not receiving a service that we want them to believe. You know, we want them to have the best that we can give them, and that's falling far short. But thank you for stepping in there, Steph. And I'm not. People are just clicking off now because they're frightened I speak to them. But I think the discussion was very meaningful, and I think the answer to the question is yes. I would say it was a unanimous yes there, and I'm getting nods, so people are.
Yeah,
and Tim's not being any more mischievous.
To summarise, to continue Tim's metaphor, if you're going towards the iceberg, you want to make sure that you've got lifeboats and you know they float. And or that you've got access to the gin and tonic if you're going to hit the ice, I suppose.
Oh dear. I'm not even going to answer that one, but it has made me giggle. Well, thank you, everybody. This is the end of this part of this part. So this is the end of the film part. I'll put some messages. Oh no, Tim's turning his sound off, I think. I'll put some messages to governing body. I'll put those out separately. But thank you for everyone for joining us this afternoon. We hope that the experience was valuable to you all. Thank you for everybody that presented a paper. Thank you, Tim, for the tree. It's illuminating. I think it's scored a plus on all of us. Phil's just clicked in. I don't know whether he's got some nice. Oh no, he's just waving nicely to us, which is.
Just wanted to say thanks, everybody. That was all.
Yeah. I think it's been a really good meeting. Thank you, everybody, and especially those that have had to dash off. And I know the pressures and the anxieties of knowing you need to be in one place and it probably in several others, which is probably all of you anyway. So bye, everybody. Enjoy the rest of your afternoon. For some of you, I'll see you later. And for the rest, have a really good day. Take care now. Bye.